Everyone. I'd like to welcome you and thank you for joining us on our latest of our COVID-19 series that we've been having. So honestly, by now we had hoped we would be able to be done with our COVID updates, but as the conditions are here, we still need to keep on bringing you updates. And I want to say a special thank you to all our healthcare providers who have been so good to us and supplying us with such nice experts who are able to talk to the subject. So I want to thank them all. So today we're giving thanks to Bellin Hospital because today we are having Dr. Bradley Burmeister, and he is an emergency medicine physician at Bellin Health. He is the medical expert and regular contributor featured on WLUK Fox 11, NBC 26, the Green Bay Press Gazette, and stations in Milwaukee and Minneapolis. So welcome and thank you so much for coming and sharing with us today.
Thank you so much for having me. Just a small shout out I want to make. I grew up in Seymour, so near the Green Bay area. I was born at Bellin, but I don't know how many people from Manitowoc know what a rock star you guys produced in a pharmacist actually down at Freighter and the Medical College of Wisconsin in Milwaukee. Matt Stanton is just one of the best emergency pharmacists there are probably in the country. And he also works at the Wisconsin Poison Center. So every day he's working to help care for little kids and adults too who overdose or are poisoned, and is just a rock star. So that's my connection to Manitowoc. So I have quite the update today. I wanted to make a PowerPoint presentation just to show some figures because I think figures are really helpful. I don't know how often people in the community look at some of these graphs. I know healthcare providers check them every day at every update to see what the latest trend is. And it's sort of interesting because in the emergency department, we've noticed that we sort of know what the trend is going to be a day or two before these graphs come out, just because it takes time for the test results to come back and for the state to review them all and for them to be published. So it's interesting to see the trends, and we'll talk a little bit about what we've been seeing in the emergency department the last few days. So I wanted to just start with this map. This is from the New York Times. It's a it's not a research-based article, it's from the Popular News, but you can see Manitowoc County here currently would be in the red. I couldn't get that box to move. Most of the Midwest is actually that deep red color right now, which is sort of concerning to us. We have a fairly high per capita case rate, and our trends seem to be overall in Wisconsin worsening, whereas the areas around us seem to be faring just a tad bit better. So we do notice that trend right now, and we'll go through a little bit more details about all of those. If we look at the hot spots, this is looking at the New York Times list of the highest per capita for each. They're really looking at cities here. They're not looking at metropolitan areas, which we'll look at in the next figure. So there's good news and bad news with this. The good news is if you look at the cities across the country, Wisconsin's really not in the top 15. If you would have looked just about a month ago, I think we were 8 of the top 11 spots in the country. So we're a little bit better than we had been. But you can see here some of the areas on the right side of this graph. Let me see if I can circle it here. We do have 5 cities or so that are currently on this list that are a bit further down than the top 15. And we have noticed an interesting trend over the last month or so that these previously had been larger cities on this list. We saw Green Bay, Marinette was on it for a while. I think Sheboygan was on the list, of course, Milwaukee. And now we're starting to see these smaller communities across our state, most of them being actually on the east side of the state. I think Menominee's over there, Rusk and Pepin, maybe Barron, I'm not sure. I was just looking at these, but Jackson I know is by Milwaukee. But the east side of the state seems to be getting a little bit more of the brunt than we are right now. If we look at just more metropolitan areas, we do see a couple show up on the list. We have Wausau or Weston on that list. We have Beaver Dam that makes it there, Eau Claire, and Fond du Lac. So we have a couple of the top 20 from Wisconsin. The good news is we're better than we were a month ago. However, the per capita rate is worse than it was. So, we are overall doing worse, but we're not as bad as other places are, which maybe is a little bit of a silver lining there. So we're going to go through each of these figures that the Wisconsin Hospital Association brings together using some state data and some data that they get from the health systems on a daily basis. We're going to talk about information that we get earlier, and then how we see that go through the system and turn into hospitalizations, and then ultimately the deaths that we see. So this graph here is looking at the positivity rate trend for the entire state of Wisconsin. This is essentially looking at the number of tests that were done, the number of positive tests divided by the number of tests that had been done. And you can see a very concerning trend since around early September that positivity rate has been increasing, and it's extremely high right now. We're looking in the 30s and 40% range. So that means 40 out of 100 or 4 in 10 tests that we are doing right now turn back positive. We do see some blips from time to time on weekends. This is a trend we see on weekends, where we see the rate either go up or down, because we seem to be doing less testing on the weekends. You can also see in the background in the gray, this is the total number of tests that were done. So we hear a lot about how there's more people who are testing positive because we're doing more tests, but you can actually see that there has not been a really significant change. In early September, we seem to have a slight downfall across our state in the number of tests that are done. But even now, we are doing more tests than we were in September, and our positivity rate is higher. So you can see it's essentially a double whammy. We're doing more tests, and the percent of those that are positive is higher. So that suggests that we're capturing more people that are infected, and there are more people infected in our community. This graph is looking at the number of people who are testing positive, and then our cumulative positive cases for the state of Wisconsin. So you can see we've had a really significant increase in the number of new cases per day. Again, you can see a few blips on weekends where we see a slight decrease, because people are not doing as much screening or drive-through testing on weekends as they are during the weekday. You can see we've had a few record days here recently, and you can see that the slope, you can see that the slope of our graph is it's getting steeper. So that means that essentially that slope is worsening, and we're on an exponential growth phase right now, which is concerning. This graph looks at statewide the percent of confirmed COVID-19 by age group. You can see here that actually the age group that had the most positive tests really have been our people that are 20 to 29 years old. Of course, everyone probably knows now that younger people tend to do much better with COVID-19 than our older population. But we also know that the younger population seems to be a bit of a driving force and bringing that virus or that infection to our more vulnerable communities, like our older population. You can see that 60 to 69 years old is only 11%, or 1 in 10 of people who tested positive for COVID-19 in Wisconsin have been that age group, and it goes down from there. So the younger group, 20 to 30 years old, they do really well with the virus, but they do seem to likely be a driving force in the infection for our entire community. Here we're looking at the total hospitalized patients in our state. You can see again since mid-September, which is a little bit of a delay from when we saw that positivity rate start to go up. That trend has been reproducible multiple times. At first, we see the positivity rate increase, and then we see the number of new cases increase, and then we see people get hospitalized increase, largely because it takes maybe 7 to 10 days before people seem to really get really sick with the virus if they're going to get sick. So there's a bit of a delay there. It's a lagging predictor. So you can see, unfortunately here too, our hospitalizations have been really on a significant increase since mid-September. We went from less than 500 patients across the whole state to almost 2,500, so almost 5 times as many patients just in mid-September. And our health systems, we've been working since March and April to get ready for something like this. We had expected maybe in March or April that we were going to see a surge like this. Thankfully, back then we did not. It's been very valuable to our health systems to have this significant amount of time to train our workforce, to train in different parts of the health system, to bring in new physicians and credential physicians. We have some people from outside of the state across Wisconsin that are helping us out now. But this has been really valuable for us to have this time. But just imagine, I know a lot of people here probably own a business, having a 5-time growth in your business over a month and a half, and the amount of time and resources that would take to have your business expand that rapidly. It's really been an incredible growth in patients hospitalized with COVID-19. I would also add that we have seen and I'll show you a graph here shortly, the percent of people admitted with COVID-19. We've seen that decrease slightly over about the last 1 or 2 months. And there's really 2 reasons for that. The first is that we are starting to test more people and do more screening. So we're capturing more people who are not sick and do not need to be hospitalized. So that denominator is getting stronger and better representative of our entire community. But also our health systems across our state have worked really hard to help keep people at home. So our home health team has worked really hard to get oxygen set up so people can go from the emergency department and go home with oxygen if that's the only need that they have. And we also have really tried to ramp up doing primary care visits or calls with patients at home when they're not doing great, but they're doing okay and prefer to go home, and it's a reasonable indication at that time. So we're starting to admit very slightly less people to the hospital than we have been, because we're better prepared to help deliver that care from a home setting. At the same time, with COVID-19, we see a very high readmission rate. Nationally, we see about 11%, about 1 in 10 patients who have COVID-19 or hospitalized end up needing to be hospitalized again within the next 60 days. And we see that largely because people become really deconditioned after they have COVID-19. They're hospitalized, they have had a significant infection to their lung, they've required oxygen. And we see a lot of patients who seem to be getting better, they go home and they just don't do quite well at home. They have an increased risk of falls, which can lead to injuries from that. And we see a lot of patients who lose their independence, even though we're able to get them to recover from COVID-19, given their age, their comorbidities, as well as the infection and what that has done to them. With deconditioning, we see that they end up needing to be placed, for example, in a nursing home. So we see that as well, which is, a morbidity that COVID-19 causes that I think is really underreported in the news. I hear a lot of, less than 1% of people die, so it doesn't really matter to our community, that's an acceptable death rate, but the comorbidities and the lifelong consequences we see in some of our population, I think, is a bit underreported. So this may be a bit of a silver lining for us too right now. Perhaps we'll be a little more optimistic here. But we have noticed this in our health system and in the emergency department. I'm actually in a string of, I don't even know, I think I'm on day number 10 of working in a row right now. But we seem to have cooled off very slightly in our region, which has been fantastic. I think we're down maybe 25% the number of people that were hospitalized last week compared to this week in our health system. And we've also seen the numbers seem to level off a bit across our region for those needing admission to the hospital. The downside, though, is I showed you the graphs where our state is having increasing numbers. The eastern and southern part of our state is really making up for that difference. We've cooled off here very slightly, but the rest of the state has made up for the improvement that we have seemed to have. We still, though, are in a fairly significant state right now. Like we are not where we really want to be from a hospital perspective. But I'm glad our region's doing great. I think that's good for our health systems. That's good for business. That's good for building consumer confidence and going out to buy things and getting out, because the people may end up feeling a little more comfortable if we can continue this trend downwards. I would also add that I hear a lot of stories about how people, particularly initially said Milwaukee and Madison has most of the virus. Milwaukee seems to be increasing now, but Madison, the city, has actually done really great at their control of the virus. They have some of the lowest numbers across our entire state, which is interesting given how close that people live in that community versus the rest of the state. This graph here is looking at the percent of COVID-19 cases in our state that were hospitalized. So we can see certainly the people who are 60 and older make up the majority of hospitalizations in Wisconsin. About 3 in 10 people in their 80s need admission, nearly 1 in 5 in their 70s, and 1 in 10 in their 60s require hospitalizations. So those are pretty high numbers from just a viral infection, and significantly more than what we see with influenza. This graph, unfortunately, is looking at our deaths from COVID-19. We can see we've had a pretty big bump in the number of deaths in the last couple of days or weeks from COVID-19. This graph is looking at the percent of COVID-19 deaths by age group. And once again, you see the same trend. We see the elderly population and more commonly needs to be admitted to the hospital. And we also see that they're more likely to die from the virus. So nearly a third of our deaths have been from people in their 80s, and a quarter for people in their 70s, and 15% actually for their people in their 60s. So those are pretty high and concerning rates. This graph is overall looking at our statistics for our state. I want to highlight two things here. First is the percent who died. Currently, we're seeing about a 0.8% rate of death from people who are diagnosed with COVID-19. We know that our actual death rate is lower than this because we are not capturing some people who have coronavirus because they just don't get tested. So it's lower than this, but that's a fairly high number. We see the same thing with influenza, where we have many people, probably more than with coronavirus, who never seek healthcare or have a positive test from influenza. But that's still a fairly high rate. And then a hospitalization rate, again, around 4.6%, which we use these numbers to predict what our strain and resources we're going to need in our health systems across the state. So last week, when we had 7,000 some new cases in one day, we're estimating that 4 to 5% of those people may need hospitalization in the coming days. So that helps us estimate our resources and our trajectory and making a forecast of where we predict we're going to be over the next coming days. So this looks a little bit more locally at northeastern Wisconsin. This is what we call our HERC region, which is essentially regions of the state that are put together for disaster response purposes. This includes Green Bay, Oconto, Manitowoc, I think Calumet, and Door counties. You can see that we're currently in a surge right now. We've seen that cool off for the last couple of days. Some of this probably is that we're coming off of a weekend, and Tuesday, Wednesday, Thursday, Friday seem to be our biggest case numbers for the week. So we are anticipating this trend will probably go up a little bit, but just in the emergency department, I think we're very slightly under what we were last week. So I'm predicting that we probably won't be as bad as the rest of the state ends up being. Again, we don't see that trend that we saw with the statewide, where it's essentially going straight up. We've seen to level it off just slightly in our region compared to the rest of the state, which that's really great to see. Though we would much rather be where we were this summer locally. This is pretty high, and it's I like to say that we're in a precarious state right now. We're able to deliver care comfortably for everyone, but we're really close to being in a really uncomfortable state, or not having the resources locally to deliver care for everyone up here locally. This is looking at our COVID hospitalizations locally. Again, you can see we have a very high number of people in the hospital. I think this probably will cool off a little bit over the next couple of days, but it's not for certain. We will see where this ends up going. We are concerned, though, that we have 47 patients currently in intensive care across our entire region. And currently the Wisconsin Hospital Association via the health systems is reporting that we have 13 ICU beds that are immediately available. So our ICUs overall are at very high capacity. Part of this is due to coronavirus, but part of this is also due to there's a lot of other people who are sick with other illnesses in our community right now as well. So we have a little bit of vulnerability here for our ability to deliver care across our entire region, given that we have such a low number of ICU beds. Bed counts are always a little bit hard to track because we always want to have a couple beds available. When our ICU is completely full, we end up needing to save a bed in our emergency department. In case that a patient on a general floor bed suddenly becomes very sick and needs to be transferred to the ICU, if there's no beds available, we bring them down to the emergency department where we have all the resources immediately available. And that impacts our ability and throughput of patient care to patients who are seeking emergency care, because we have 4 critical care beds. And when you take 25% of those away, that really can impact our ability and throughput for patients and worsens wait time. So there's a lot of downstream consequences of being this tight on ICU beds. We like to have it a little bit open. It's also important to know that people are always coming and going from the ICU at any given time. So we need to shorten that throughput of cleaning beds and turnover so that we can keep things moving along. Okay, so just a little bit of a shift here. Is there any questions so far? No, okay. If anyone has questions, feel free to put them in the Q&A. I'm happy to try to answer them. Another graph here, we're looking at our Wisconsin surveillance of respiratory viruses by PCR. So this graph notably does not include COVID-19 on it. This is a graph that the state puts out every week or every other week during our influenza season. It has a lot of information on it from our regions across the state to help us know what influenza typically looks like. But we do have a couple other viruses that are circulating across our state right now. Most commonly is this rhinoenterovirus. Those are viruses that cause the common cold. We see a bit of adenovirus that's floating around. And then also you can see there's coronavirus seasonal on there. There has been some confusion on social media about things like this because there is a family of viruses that are called coronaviruses, and then there's several subtypes within that family of viruses. There's probably 4 that seem to circulate and have been circulating for a long time at fairly low rates that cause the common cold. But there's also COVID-19, which is significantly more virulent than the other viruses in that same family, which means that it makes people much more sick than the other coronaviruses do. This is part of the reason that antibody tests make us a little bit skeptical, because the viruses have very similar DNA to them, very similar structure to them. So when we do antibody tests, there's a possibility that there could be some overlap with the other coronaviruses that we see circulate and COVID-19. And I don't think that we've come to a point yet where we've had really strong data to know if someone is testing positive for a COVID antibody test, to know with certainty that it's COVID-19 and not another coronavirus. And that's why we haven't seen strong recommendations quite yet come out that say, if you've had a positive antibody test, you for sure have had COVID-19 in the past. There's a little bit of a question that comes up with that, and the test doesn't end up being as perfect as we think it would be. But that's just an important thing to know. So if you see on social media someone talking about coronavirus, just make sure you know that they're talking about COVID-19 versus our other coronaviruses that circulate, because that has been a bit of a problem, especially early on in this pandemic, with providing education to people in our community, because a lot of people were pulling information and posts went viral using data from the coronavirus family and not COVID-19. So here, I just wanted to touch a little bit on, first we'll talk about the influenza vaccine. The influenza vaccine is something that we really strongly recommend that people get this year. We know that our hospitals are at very high capacity, and we want to do everything we can to help prevent further need for people to be hospitalized. And one key way that we can do that is by trying to make sure that we get everyone who can get vaccinated for influenza vaccinated to help prevent the spread and the endemic that we see with influenza each winter. Right now, we are just a little bit over 4% higher in terms of the number of people who have received their flu vaccine in Wisconsin compared to the same time last year. So it's great to be 4% higher, but we would like to be a little bit better than that. And this data notably is through the end of October. The first 2 weeks of November have not been released quite yet. We've seen about 30% of people who are eligible to get their influenza vaccine in Wisconsin this year have received it. Last year, 42% of people in Wisconsin received their influenza vaccine, were eligible. Our Healthy People 2020, which is a state program, wants us to get about 70%. But we think that's really a key number to help get towards that herd immunity that we've heard a lot of people talk about with COVID. We think that if we could get 70% of people vaccinated with influenza, we could potentially get that herd immunity we need to help keep our community healthy and strong and protect those vulnerable populations. So we see this trend with influenza where we have a small marginal increase on last year flu season to date. With COVID, we are very optimistic. We've had 2 vaccines, the Moderna and the Pfizer vaccine, that recently announced some very preliminary data on their vaccine, and it seems to be really favorable. Coronavirus historically has seemed to be a virus in that family that is hard to make a vaccine for. But with new technology and having so many people working on it, they seem to be producing results that are better than have been expected. Would give the caveat yet that this data hasn't been published to be peer reviewed quite yet. So we haven't been able to really scrutinize it from a medical lens to see exactly how they got that data and what things look like and what their methods were. But that's really fantastic results to see. And we're really optimistic that if we can get a good uptake of that virus or that influenza in our community, that we'll be in a really good spot. Because we want to get towards that herd immunity. The sooner we can get towards that, the sooner we'll see the reproductive rate, or the R naught, if you've heard of that phrase before, become less than 1, and eventually the virus will start to diminish throughout our community. So it's going to be really important that once the COVID virus or COVID vaccine is able to be distributed, it likely will be on very short supply when it first comes out. But we want to encourage anyone eligible to get it done when it's available to them. And I'm hoping that we can be slightly more favorable than we see with our vaccination rates, which are a little bit less than we would like to see right now. So then I have just some frequently asked questions I put on a slide that I wanted to go through. And these are all great questions. And if there's more, please let us know. The first is, what's the difference between quarantine and isolation? Great question. For people who are a layperson, probably not that important, but some medical people, like, this is a big thing for them. So quarantine would be as if you're exposed to someone, but you don't have symptoms and you haven't tested positive. That's a time period that you're in, so that if you end up getting symptoms or you end up testing positive, you're not exposing other people. So we put you in quarantine. So we've heard, previously, I think there's a movie about, what's it called, Pandemic or something. It's actually a pretty good movie. But they had people come off of planes and they put them in quarantine in their house. They said, you're coming home from this country that has this virus that no one else has. So once you get home, you have to stay home for 14 days and you can't go anywhere. So if you do get sick, I don't want to use the word isolate, but you're not exposing other people and causing that virus to start in that community as well. Whereas isolate means that these are people who have symptoms or have tested positive for COVID-19, and now they're isolating away from other people. They're no longer quarantining because they're actually sick with it. So for all purposes, they essentially mean the same, that you're not going by other people, you're staying as far as you can from other people, including your family and your own household. So like the mechanism that you are following is the same, but the purpose of it, is a little bit nuanced. Do you need a slip from your doctor to go back to work? Great question. It's probably based off of the employer's requirements. Certainly when we see people in the emergency department who have COVID-19, we do provide them with a work slip that lets them know what their period will be. The hard part is that those are only for people who we get a result or have had a result while they're in the emergency department if they've been tested previously. And some people won't get tested for a day or two. So somehow we have to be able to figure out how to get them that work note. But certainly the providers are happy to provide a note, but it's up to the employer what their exact requirements would be. And I think that'd be left up to your workplace's policies. Do you need a doctor's order to get tested? You don't, for the most part, at these drive-through sites all across our region. You just have to call the number or use the app that's available, or do I need a covidtest.com if you are planning on using the UWGB rapid testing site. So like technically you don't need a doctor's order. You don't need to see a physician to get tested. With kids potentially coming back from school for the holidays, how should families deal with that situation? This is a really hard question. there's things that you can do that potentially reduce the risk. The first would be encouraging your kids not to, go out to the bars or whatever 14 days before that Thanksgiving holidays. So try to decrease their risk of exposure for that time period. Now, obviously, some kids need to go to class, but when they're going to class, try to just be extra vigilant with wearing that mask and trying to distance from others during that time period to help decrease that risk and then bringing that virus to families at home. Also, I think all UW campuses in Wisconsin have that rapid testing availability. I believe that Tommy Thompson, our previous governor who is on or leading that effort, has either encouraged or required kids to get a COVID test. I think it's when they're returning, they actually have to get 2 tests done, but they do have testing availability so that kids could be tested before they head back home. That's not a perfect test once again, though, because if they had just recently been exposed, they're more likely to have a false negative test, and there's a possibility that they could develop symptoms between their exposure and that testing afterwards. So it's not perfect, but certainly if someone tests positive, that would help them know not to, potentially go home and expose other family members. And then lastly, once you're at home, just recommend to continue to try to keep a little bit of distance between yourself and loved ones who don't routinely live in your home. Can a family have a gathering if everyone has a mask on and stays 6 feet apart? There's a spectrum of recommendations for this. Certainly, ideally, at this point, we really recommend that people try to stay home and do Thanksgiving and, possibly even the, Christmas holidays virtually if you can. If though you are going to meet in person, the next best thing would be to have everyone wear a mask, keep that 6 feet distance apart from people. Certainly if anyone has symptoms, they shouldn't be attending. If anyone's had a close exposure, would recommend that they don't attend that event either. And then also when you are sitting down and eating, trying to be far apart from each other, use a couple different tables. My family typically sometimes uses the garage when we have larger gatherings. So maybe keep the gathering smaller and have tables in different parts of the garage for each different house. That might be helpful in helping maintain that distance. And then we also want to encourage people not to share utensils. So try not to have a buffet line of people using the same utensils, and have hand sanitizer available so people can wash their hands frequently. So we would much rather prefer people do that than have their, the status quo of having large family gatherings with everyone sitting at the same table close together. We want to do everything we can to reduce that risk. Do you have to isolate for 10 or 14 days? Another good question. If you were exposed to someone but have not had a positive test, then you quarantine for 14 days after that exposure. If though you have symptoms or you have a positive test, then it's 10 days since onset of your symptoms, as long as you are feeling better for 24 hours before coming off that isolation period, and you're not using any fever reducing medicines like Tylenol or ibuprofen to mask that fever, I'll say. And then what are the best practices to avoid getting a false negative test? Great question. One of our big sayings here at Bellin is that you can't test out of quarantine, because we've seen it time and time again where people have an exposure, they get tested, and then they end up getting sick. And then, we see them in the emergency department, like, oh, what have you been doing? And they're like, oh, I went back to work, and now all these other people are exposed, and it's just awful from there. So that's an important thing to know, is you can't test yourself out of quarantine. But I think what this question is getting at is how to avoid getting a false negative test in the first place. And we give a soft recommendation to people that you want to wait maybe 4 days after a very close exposure you've had to get that test done. If you have a close exposure, you immediately go in and get a test done. It's very, very likely it's going to be negative, because that virus needs some time to infect you, to replicate in your respiratory tract, so that it can end up becoming a detectable level. So you ideally want to give a little bit of time between that exposure and when you're getting that test done. That's going to increase your sensitivity or your ability of that test to pick it up. So that's a great question and important to follow. If though you even have waited 4 days after that close exposure and your test is still negative, you still need to quarantine for that whole 14-day period from your close exposure, because there's still a risk at any time in that 14-day period you could end up developing symptoms of COVID-19. And it's just so helpful to keep people at home rather than having further negative consequences on our economy and whatnot of that person potentially exposing a larger group of people. I think that is all the slides I have for now.
There are some questions, Dr. Burmeister. This is Kristen. The first question is, how careful do I need to be if I already had COVID?
Great question. Currently, the recommendation is to continue to follow all of the public health guidance of distancing, masking. Currently at Bellin, we have elected not to test people within 90 days of their previous infection, because we believe that almost everyone who is going to have some immunity to COVID-19 for that first 90 days. I don't know if I misspoke. I meant 90 days. Did I say 30? 90. 90 days. We have seen a couple cases of reinfection locally that I have heard about from a couple different health systems where people were infected in April or May, and they ended up having symptoms again, just in the last month or two. So we do know that people can get reinfected. Thankfully, the cases I have heard about all have been relatively mild both times. But it's a little bit poorly understood of what exactly your risk is going to be. There's also this theory that people who have are immunosuppressed for whatever reason, they might not be able to develop those antibodies that circulate in your blood that protect you from COVID-19. So those people may also have an increased risk of reacquiring COVID-19 and potentially sooner than other people. So because it's not perfectly known and there's a lot of questions yet about what your risk is, we still recommend that everyone follow all of those recommendations. I'm a bit optimistic because the CDC, they call it an MMWR, Morbidity and Mortality Weekly Report that they publish. They published one maybe a month ago, actually based in Wisconsin. There was a summer camp in southern Wisconsin where people flew in from all over the country. They had to have either an antibody test that was positive before coming to camp. I think they had to have 2 negative COVID swabs, and they were supposed to be isolating at home, quarantining at home before going to the camp. And so they got together, and then unfortunately one person had COVID-19 and it quickly spread throughout the entire camp. I think probably it was like 100 out of 140 people tested positive for coronavirus before this camp was over with, and this was mostly adolescents. But interestingly, everyone who had a positive antibody test at this camp, none of those people got coronavirus during summer camp. So that is really interesting, and that's why I think why the CDC had published that report. But at the same time, one of the caveats were that they don't know if who all had antibodies, because not everyone had an antibody test before going. So they don't know if some people would have had positive antibodies before going to the camp, if that makes sense. So that was exciting.
I have a second question for you. What percentage of individuals who test positive have no fever?
That is a great question. I don't know the exact number. I think just in our clinical experience, many people have a fever. I don't know that I would say most, but many people have a fever. Usually people, and I don't have medical evidence to back this up, but it seems that, people who have what we would think would be strong immune systems, so younger people, seem to oftentimes develop a fever a little bit easier than elderly people or people who are immunosuppressed. The challenging part is that, we've been doing a lot of imaging this pandemic, which is interesting, but we have a lot of people who come in and have really, really vague symptoms, and just, theoretically, they end up getting a CT scan for some reason, which happens all the time. And you end up seeing part of their lung on the CAT scan. For example, we've had several cases of people who've come in with appendicitis or another abdominal problem. And when we do that imaging of their belly, we see their lungs. And there's very unique findings that COVID gives to your lungs on a CAT scan that we have seen we call that an incidental finding, where we weren't looking at their lungs. We didn't think that they were recently infected with COVID or actively infected, but we've had a lot of those people as well. So, we've talked a lot about asymptomatic people in our community who have coronavirus, and we have some people that don't have the classic coronavirus symptoms, but then certainly we have the people who have that fever, cough, sore throat, loss of taste or smell as well. But I don't know the exact percentage.
All right, we have another question. Is it recommended that an individual test for COVID if the spouse tested positive?
That would be a very appropriate situation to get tested. Certainly, I would assume there would be a close exposure if it was a couple in that situation. So if you are, living with your spouse who has COVID-19, you would want to have the quarantine period for 14 days. And the 14 days is after your last exposure to them. So some people, based off their living situation, they can't isolate or quarantine away from each other in the same household. But we have had some people who have been able to have one partner living downstairs, one partner living upstairs during the duration of that. And then they've been able to have that exposure only be the 14 days, versus it could end up being 24 days if you're going to continue to share the same room or the same, common areas of the house and have a repeated new exposure, because it's 14 days after your last exposure to them.
Perfect. And I have one other question that came through. Is there any truth that the COVID virus is beginning to weaken with severe cases decreasing?
I had heard that. I don't think we have strong evidence that that's the case. Our hospitalization rate in Wisconsin has been fairly steady. We've seen it decrease slightly, which I suspect is because we are better able to, we have more robust testing than we did early on when I think in April, our hospitalization rate was like 20 or 25%, which we know wasn't true, but we just weren't capturing that denominator adequately of people who weren't as sick. We were only testing people who needed to be in the hospital really early on in the pandemic. So I don't think the virus is weakening. We continue to see just awful cases of people who are extremely miserable and really, really sick with the virus. But that is a good question. The challenging part of this is, even with these people who have been reinfected, it would be nice if we could analyze the DNA of the virus and see if the virus has changed at all, or is it the exact same virus the person got twice? But we don't have capability in this country, probably anywhere in the world, to keep how many million people have tested positive for COVID, to keep all those samples in a fridge somewhere, so that when someone has a unique situation, we can grab that last test, because it needs to be frozen essentially, and compare the two DNA structures. So I don't have strong evidence that's the case right now. It would be nice though.
Perfect. Thanks. I have one other question. It came through and it asked, is the virus mutating?
Pretty much any viral infection that travels around gets tiny changes in its DNA with time. We see that with influenza each year, where the type of influenza strain that's predominant in our community changes. That's why we have influenza A, that's why we have influenza B, because it's the same type of virus, just with little changes in its DNA structure that's out there. So, with certainty, there are small changes in DNA. The significance of those small changes are never really well known. And also, typically the mutations that make the virus stronger are the ones that persist. So typically, if it gets to be weaker, we usually see that virus slowly go away. But if it gets stronger, that's the one that becomes the predominant strain with time.
Thank you. That completes all of our questions. So I'll just turn it back to you for closing comments.
All right. Well, thank you so much for having me. I hope this was informational, and would be happy to share any other information or questions that come up in the future.
Thank you.